Fear. Right now, there is a lot of fear because of COVID-19. People are scared of leaving their homes, scared of shaking hands with humans, and scared of going to hospitals because that is where COVID-19 patients go. So even if we need to see a doctor, we stay at home, and sometimes waiting could make things worse.
When news of COVID-19 spread, people stop coming to the hospitals. Even if they are not infected by the virus, they become infected by fear.
But did you know that hospitals may be the safest place in the world right now? When they started admitting COVID-19 patients, they had isolation rooms and special wards for these patients. One ward for COVID-19 patients, separated from the rest of the hospital, leaving the rest of the hospital safe for everyone else. So every time a COVID-19 patient walks in, they get dedicated nurses to take care and support them.
Safety is our number one priority all the time. This helps to keep not just our staff, but also our patients and the general public safe.
They have doctors that specialize in infectious diseases, separate security 24/7, separate disposable cutlery, and even separate air ventilation systems to make sure even air doesn't go to other parts of the hospital. This separation is vital to keep everyone safe because for all other patients, it's the new norm. Many people still need hospitals, especially when they have worrying symptoms like chest pain, vomiting, or sharp pain in the stomach that need urgent medical attention.
Because of our very strict protocols and safety measures, our hospitals are safe, and that is a fact.
Because everyone, from senior management to doctors to nurses to security guards to chefs, is doing the impossible to keep the hospitals safe for you. So, only if you need urgent medical treatment, stay home, be safe, and keep healthy. Health insurance is complicated, so let us simplify it for you. This is a plate of delicious fried rice. It's like the basic health insurance that we all enjoy. It can protect you when you fall ill and get hospitalized, and helps you save money. But what if you had the choice to upsize it? Add this, and this to your meal. All of a sudden, your meal has more flavors. With private health insurance, you can enjoy more options. Your hospitalization and surgery are covered. You can choose your own doctor and see them in 48 hours. You just need to focus on recovering and leave the rest to them. Healthcare isn't supposed to be confusing. It's supposed to help you.
All right, thank you for watching us live and welcome to the Mount Elizabeth Hospital, our annual medical seminar, Lunchtime Webinar 2020. My name is Charlene, your host for this afternoon. In fact, this event is jointly organized by Mount Elizabeth Hospital as well as Mount Elizabeth Novena Hospital. This is our very first virtual event, and this is going to be done over 4 lunchtime webinar featuring over 9 leading medical experts from around the region. So today we'll be touching on the topics of the new norm to bring healthcare forward. And also we're really delighted to be hosting this and presenting this right now at the Presidential Suite at Mount Elizabeth Hospital. So today let me just showcase the topics that we have with us. We will be presenting on learning to work and live in the COVID-19 era as healthcare workers, and also the common adverse effects of childhood vaccines. This will be presented by Dr. Ashok Kurup, the infectious disease physician, as well as Dr. Liu Wei Kang, our pediatrician from Mount E Novena. Next up, we will also have a panel discussion, and this is going to be moderated by Dr. Liu Ho Nam, the infectious disease physician here with us. And also, we'd like to highlight to you guys that you can also watch this via our Mount Elizabeth Hospital YouTube channel. A gentle reminder for you to log in and also for doctors to clock in your CME points. Finally, for our viewers who's watching us live on the YouTube channel, you too can be penning down your questions via the comment section at YouTube. Now, our staff will also be forwarding your questions to our moderator. Remember our hashtag for this event? It is MAUEAMS. So if you're posting on the social media, do include this hashtag and tag us. Now, of course, if you encounter any technical difficulties, please contact our crew who will be on standby to assist you. All right, so without further ado, I'd like to welcome our very first speaker for the day, Dr. Ashok Kurup. He is the infectious disease physician at Mount Elizabeth Hospital. His clinical experience and expertise encompasses managing diverse infections, ranging in complexity from outpatient to inpatient care. So please join me and let us welcome Dr. Ashok Kurup.
Well, thank you very much for that kind introduction. Unfortunately, my talk is yet another talk on COVID-19. But, we are all in this little pickle with COVID-19 because, we are caught in this jam. We can't escape from it, and it's not mitigating or abating the world over. So I hope to share some salient points with you about safe living, especially as healthcare workers, as we move forwards, how to live safely in this era of COVID-19, because it's a long-term health threat to public health, and the pandemic is unfortunately far from over. It is the most disruptive infectious diseases in a century. And unfortunately, there are a lot of unknowns about the disease, and we risk an explosive spread anytime. Unfortunately, it's not going to end with just a vaccine. Plus, there is a lot of issues with regards to COVID fatigue, and we know that from a public health standpoint. So this is my brief outline. I'm going to talk about some of the facts that we as healthcare workers need to be aware of. For example, keeping up with some of the evolving clinical features of COVID-19 and understanding some of these things and bringing in overseas patients safely. Some aspects about immunity post-COVID, actually maybe more questions than answers, and some issues about the new normal, especially with regards to aspects on safe travels. So what are some of the discriminatory features of COVID-19? I think most of us are aware of the respiratory symptoms, fever, etc. But I think you are aware about anosmia and ageusia or dysgeusia. And depending on where you read, it has been reported to up to 70% of patients and are more common in women than in men. So take note of that amongst the patients whom you see. And as we know, it is not just a respiratory virus. If you have a critical illness with this condition, it can involve multiple systems from respiratory, causing a condition called ARDS, to all the hypercoagulability issues that we may have heard about, thromboembolic complications, as well as Kappa. Now, this is COVID-associated pulmonary aspergillosis, and from a Spanish study, a third of their patients had this in critically ill patients, a median of 4 days after intubation, and it was associated with steroid use with a mortality at 30 days of nearly 44%. So these are just some of the clinical syndromes that we are beginning to understand, and I think we have to go with the science so we appreciate what's actually going on in the outside world so we can apply them to our patients when we see, especially cases that come in from abroad. Now, to add to the list of cases that can present with a vesicular rash, we are familiar with shingles, herpes zoster, herpes simplex, but guess what? COVID-19 can also cause a vesicular rash, and it's been reported to appear 4 to 30 days after the onset of COVID symptoms and resolving in a median of 10 days. So there is another syndrome that we need to think about, and it's called post-COVID syndrome. And it's defined as symptoms that goes beyond 3 weeks from initial onset of symptoms with chronic COVID, some people call it long COVID, extending beyond 12 weeks. So the symptoms described includes dyspnea, fatigue, joint pains, brain fog. And unfortunately, it's very difficult to tease out what are facts in an infodemic and what is actually just purely media hype, because media can also entertain a lot of fallacies about this. So we don't know. Anyway, I think a lot of us are familiar with the MIS-C, which is a multi-system inflammatory syndrome in children, which has got overlaps with Kawasaki's disease. But here is the multi-system inflammatory syndrome now described in adults. And this is from March to August 2020, a report out of UK and the US, which is a severe illness requiring hospitalizations in persons more than 21 who have either current or previous SARS-CoV-2 infection and who have severe dysfunction of one or more extrapulmonary organ systems in the absence of severe respiratory illness. So some of the things that we have to still keep up with. So once we have to understand these things, we got to go to responsible sites like maybe the New England Journal or the Lancet, etc., to better understand some of these things rather than just reading all over the internet. Now, bringing patients from overseas, this is an important thing that a lot of clinicians must know. When you tell your patient and or their caregiver, they should have enough financial resources and insurance coverage, because they should be very transparent. They should know that they have to spend quite a bit of money here in Singapore. And there is also the cost of isolation, etc., etc. And please advise your patients to declare if they had COVID previously, even if they had recovered. A lot of patients have had COVID. They will not tell you. They will not tell the authorities. And when they come to Singapore and they get tested, then they will say, oh, I had COVID before. And then you will have to go rummaging, a lot of distress for the patient, relatives, and you cannot deliver the care that you expected to deliver. And fundamentally, recovering COVID patients who test negative can sometimes test with detectable PCR tests subsequently, and this is a very common phenomenon. A lot of patients who had COVID and they recover, and then they're suddenly shocked and surprised and devastated that they are still positive. So how long can PCR be detected? This is a local study. The mean viral shedding by PCR was, PCR is polymerase chain reaction, I think we're all aware of it, was slightly over 2 weeks, 16.7 days to be exact. And the cessation of viral shedding by PCR occurred only in 4% by day 7, but by almost 80% by the 3rd week and over 90% by day 28. But do note that even after a month, some people may continue to shed. So when is a patient considered non-infectious? So our local experience is when there's no virus isolated from samples where the CT value, which means the cycle threshold value, how many steps in the amplification process of PCR is needed to detect it, and that magic number is 30. And if you get more than that, means the viral burden is very low. Or when the sample was collected more than 14 days after symptom onset. We have a prevailing public health time-based criteria right now, which is if you have an asymptomatic patient who has a positive PCR swab and a detectable COVID-19 antibody, we endorse that patient as day 15 from the day of the positive serology test, and then we have to keep the patient isolated until day number 21, releasing them on day number 22. However, if you have a negative followed by a positive swab, with high CT values and an antibody that's positive, that individual may be considered non-infectious. However, please note that immunocompromised patients with COVID-19 may shed viable virus for 2 months or even longer, so this does not apply to all. So a little graph to show you that when you detect virus at the low end of the viral RNA syndrome, 6 weeks or so, you may still detect some viruses even though you have already developed antibodies. and this person does not necessarily be infectious. Briefly about surgical risk in COVID-19 patients for the surgeons amongst the audience, please note that there are lots of studies outside, and there's one international multi-cohort study that's been done to show that 30-day mortality, if you do on COVID-19 patients who are undiagnosed, is nearly 25%, with pulmonary complications in half that patient. So it's important to know this. So what do people do overseas? Well, many centers require 72 hours pre-surgery swab, and some require ×2, and depending on what kinds of interventions, whether it's neurosurgery, dental, ENT, or scopes, etc., people decide also whether it's elective, then they do RT-PCR, or if it's an emergency or a therapeutic one, then they can do a rapid NAT-based study, which is a nucleic acid-based study. So some things like that, we may not need to do all that at the moment, but if we have a lot of unlinked community cases here in Singapore, we may have to entertain that as well. Some people ask about how safe the hospital environment is. If you have watched the videos just now from the corporate team, I think you would know that it is very safe. Droplet is still the most important mode of transmission. There is a lot of discussion about airborne transmission, but in the detail, physical distancing helps a lot. So we know, therefore, that droplet is the mainstay. There are some aerosol generating procedures which we know we have to be careful about, and then you have to wear the N95. As you know, all the wards have separate air handling, and transmission to adjacent rooms, corridors, and floors across the whole world has not been described. Some people say, why not open up the windows in the hospital? That's not a good idea. You can get fungal infections in your immunocompromised patients. Now, the million-dollar question, is there immunity post-COVID? Well, we know that the antibodies can be detectable 14 days or so after the development of symptoms, but it is not an immunity passport because the correlates of immunity are not yet known. But to let you know that we have a local study that looked at people who recovered from the first SARS-CoV-1, and those people were still having T-cell, long-lasting memory cells to the original SARS-CoV-1 17 years after the outbreak. And these T-cells actually were cross-reactive to SARS-CoV-2. Additionally, in New York City, more than 30,000 patients were studied, and more than 5 months after recovering, they still had robust titers of IgG antibodies. A lot of them were detectable, neutralizing. Sorry, there's a typo for the detectable. So very quickly to prevention, we know the risk factors for severe COVID, and I would not labor it or belabor it, but we know that we as healthcare workers, as well as for our patients, we got to get it right by way of all those aspects I've listed on the right. In addition, I think we all know that this has been debunked about whether or not hydrochloroquine works as a pre or post-exposure prophylaxis, and you know all the details about that's not actually adequate at all. But how about vitamin D? There's an association between low vitamin D levels and a high risk of testing positive for COVID-19, and people who are hospitalized have lower levels and controls. In fact, there is a small randomized trial that showed that there's a possible benefit of giving vitamin D, but please note that low vitamin D levels correlate with poor health in general anyway, and there are many failed studies of vitamin D treatment for a wide range of conditions, including critically ill patients with respiratory failure. So the jury is really out there. Not quite clear, but anyway, no harm in giving vitamin D. Now, another million-dollar question about vaccines. We know all about the mRNA vaccines that's been coming out. It appears to be safe so far with efficacy of more than 90%. Please note 2 different studies have come up, 2 independent study groups, and they show similar results, but then you need 2 shots as far as the Moderna and the Pfizer-BioNTech is concerned. The Moderna vaccines neutralizing antibodies have been detected even after 90 days after the second dose, and this is evolving data. Now, I beg, beseech, and implore the audience and all healthcare workers listening in to please stick with the science. There's so much of unfounded claims about mRNA, and people like to share all kinds of information on social media, so please follow the science. Now, in the interest of time, I will not be talking about outpatient therapy for COVID-19, really monoclonal antibodies. We don't really know what is their role, although there's some studies that have come about. Now, reducing the risk of acquisition, I think this is important, and you can just look at the cartoon pictorial. It's very difficult to say that it's binary. There are so many confounding variables here, and it's like a spectrum. You have to look at all kinds of different entities when you think about your risk and how you're going to acquire it and how you can potentially reduce the risk. But please note about household transmissions, because if you bring in an ill colleague or an ill family member from overseas or somebody who has been overseas, please note the data shows a secondary infection rate of 53% amongst household contacts, very, very high. So your risk may not be where you work, etc., but it may be in a situation where there is not that much of, social distancing, and you take out your mask, etc. Where does that happen? At home. Where does that happen? At work, in the tea room, etc. Is it safe to attend a local event? Well, please note a lot of these things are happening, but we have this antigen test. It's not so sensitive. You may all be aware of the evolving news right now about what has happened in the cruise. So it's at your own risk right now. I think before a vaccine is available, please note that the rapid testing's sensitivity is low, although their specificity is high. So you might want to be more careful about what kinds of events you choose. Finally, is it safe to travel? Well, the absence of large numbers of published in-flight transmissions of SARS-CoV-2 is not definitive evidence of safety. There are probably less than 50 cases so far that's been described. But at the moment, based on circumstantial data, strict use of masks appears to be protective, because that's what they did in this study. In the Emirates Airlines that were flying from Dubai to Hong Kong with rigid masking policies, they did not find any secondary cases, etc. And they found that these people who were COVID positive were sharing the cabins with large numbers of persons who did not get infected. Nonetheless, my opinion, I think several would share with me, is that leisure travel would not begin until possibly 2022. So I don't want to end on a very horrible note, but I would think that we should still stay positive no matter all the grim news. Christmas is around the corner. Please do not give in to COVID fatigue. We are at the brink of some control because we do have vaccines. We have to share science with each other, and we have to move on in this way, and we must not expose our weak link. All right, thank you very much. Sorry I took up so much time.
Thank you so much to Dr. Ashok Kuruk for the insightful sharing. We learned so much, so let's stay positive. That's right. And during this lunchtime webinar 2020, right now, we'd like to welcome Dr. Liu Wei Kang, who's a pediatrician of the Mount E Novena. He subspecializes in pediatric immunology, rheumatology, as well as allergy, and provides comprehensive care in allergy disorder. His topic today is on the common adverse effects of childhood vaccines. Dr. Liu, please.
Hi, good afternoon, everyone. We'll switch gears to talk about childhood vaccines. So we have chosen this topic partly because the NCIS have updated their schedule recently, and I have a lot of queries from my colleagues regarding adverse effects. Okay, so why vaccinate? We know vaccines are still saving lives. They prevent 400 over million illnesses. These are US data, help prevent close to 1 million deaths and lots of healthcare costs. UNICEF is big in helping the world prevent vaccine preventable illnesses by purchasing and distributing the vaccines. If you look at the chart on the left, vaccines have definitely over time saved mortality. The smallpox vaccine is a good example, introduced in the 1950s, ended in the 70s with the eradication of smallpox in the world. And for paralytic polio, largely eradicated. It's not just the mortality, but also the morbidity. Common childhood illnesses like measles, mumps, rubella, diphtheria, including pertussis, have all been largely reduced. I guess this is not a talk on how vaccine work. I think we are all eagerly awaiting the sort of like trials of the COVID vaccines, but suffice to say, after the injection, your cellular responses take over. It primes your T cells, make your B cells produce antibodies like the IgM and then the IgG. And because of that, you need a few booster doses because they are usually cute vaccines with a resultant secondary response with a booster shot. But this is part of the problem because whilst we are very successful in preventing many of these vaccine sort of like associated diseases, Again, fatigue and complacency will come in. You would have patients that would accept all your advice versus those who are anti-vax in the first place. And then with time, with outbreaks, for example, the measles in 2018, it's coming on because people are complacent and starting to sort of like avoid some vaccines. And then sometimes sort of adverse events can make them lose confidence in their vaccines. So I think as all healthcare givers who are providing vaccines, we need to understand what makes people go for the vaccines. The perceived benefits must definitely be more than the barriers. We have to give the parents a peace of mind, and then they will accept your vaccines. So I think we're going to focus this talk mainly on adverse events following vaccine. So I'm going to break this up mainly into 4 big groups: the vaccine reactogenicity, the vaccine hypersensitivity kind of reactions, specific vaccine adverse effects, as well as how we can notify. Okay, so this is very common, vaccine reactogenicity. It refers to all subset of reactions that happen soon after the vaccine. They are usually a physical manifestation of the inflammatory response. Some of the local response may include pain, redness, swelling, or induration of the injected vaccine. So if you look at the cartoon on the right, after the injection is given, inflammatory, a danger signal is given out by the sort of like muscle fibers, sense of cytokines to the rest of the body for pain, and to the systemic acute phase reactants that is made in your liver, and hence you get systemic symptoms like fever, myalgia, headaches, or rash. These are quite mild reaction. Even the one in the picture is already a bit more exaggerated local reaction. But in most times, you don't see any swelling or pain. The child is just quickly forgotten the vaccine outside the clinic setting. But in some cases, you can see some mild inflammatory response with pain, redness, and swelling. Up to 48 hours post-vaccine is quite common. The rest of the local reaction is less common, like subcutaneous nodules, as well as localized eczema. But these are the large local reactions called the Arthus reaction that sometimes make the patient very angry with whoever has given this vaccine. So you need to be aware this is a phenomenon because of a type 3 hypersensitivity type of reaction. It's usually a pain, swelling, and exaggerated swelling with a lot of local edema, usually beginning within 48 hours following immunization. It can happen even in young infants, partly because people thought it's due to high maternal antibody level. So it's a antibody antigen complement activation reaction, resulting sometimes with too frequent tetanus-containing vaccine. But in most cases, they are benign. They resolve within 1 week. And sometimes it's difficult to differentiate with a true cellulitis, but in most cases, it can be sort of like soothed with just anti-inflammatory medication like Brufen, some icing, and it will go away. Some of the published sort of like local reaction, I often tell the parents to expect maybe 5 to 10% may have a local reaction. For the pertussis, the DTP vaccine, since we switched to the acellular pertussis vaccine, these seems to be a lot less. Fever, again, ranging between 5 to 20% for some of the vaccines. And if you look at our new NCIS schedule, there are more combination two shot situation. Sometimes the fever can be a bit higher. So we need to understand that vaccines can cause reactogenicity, and these are some of the simple steps, I guess, as doctors, we can reassure the patient, be very proficient in what we do, giving it sort of like in a soothe the patient. I think distraction usually helps a lot. And if you have 2 vaccines, you usually start with the less painful one. Usually I find that the subcutaneous vaccines like the MMR, the flu vaccines sometimes are less painful, so I like to start with them. And the rest of the vaccines are usually intramuscular, so select your needle length and the gauge of the needle properly, because some babies are really chubby and some are really thin. Don't warm up the vaccine prior to the injection, and it's recommended you don't need to aspirate before you inject, so just go for your landmarks and push in the vaccine. This topic has been sort of like well studied. We suggest avoiding prophylactic paracetamol or ibuprofen, partly because there are some studies that showed that reduced reactogenicity to the vaccines following if you give the paracetamol or ibuprofen prophylactically, but it's definitely fine to treat any fevers that come along so that the child doesn't have any discomfort. So talking about vaccine hypersensitivity reactions, this again is a common source of referrals to us. Sometimes urticaria reaction, asthma attacks have been reported post-vaccines, and rarely anaphylaxis. The more common vaccines include the measles, the DTP containing, as well as Hep B vaccines, but they are exceedingly rare for anaphylaxis, reported in less than 2 cases per million. When we evaluate for vaccine hypersensitivity reaction, we pay attention to what are the common components of the vaccine. And I guess it's useful to know as healthcare givers, most of our vaccines, the active component make up only a small segment. And the rest are adjuvants, antibiotics as used in the process, stabilizers like gelatin, preservatives, thimerosal is no longer used in most of our childhood vaccines, but in multi-dose vaccines, sometimes it's present. Trace components can sometimes be still found, like in formaldehyde. Okay, some of the culture media are the main source of culprit for these hypersensitivity reactions. So we have tables like this. For example, in the top, gelatin is found in a few vaccines like the Merck strain of MMR, Verivax, as well as yellow fever and zoster vaccine. I've got a slide on egg hypersensitivity later. And in these referrals, sometimes we look at the vaccine that is isolated, keeping in mind that other common things can happen, for example, food allergy. If we choose to do a skin test, it will be against the components of the vaccines, and also sometimes we do blood testing for these components. And in the picture on the right, someone has reacted to alpha-gal containing gelatin vaccine, and you can see the skin test for MMR, for varicella, and for gelatin all comes up, and this is how we can isolate and tell the patient it's not because of the MMR vaccine, it's because of the gelatin component of the vaccine. Egg allergic patients make up about 2% of our children, so you need to be a little bit wary of this when you give your egg containing vaccines, which are MMR vaccine. This contains a tiny, almost nil to traces amount of egg protein, so it can be given safely in the primary care setting. We used to advise patients to be observed for about 30 minutes post-vaccine, but the latest guideline says no need. Special precautions in egg anaphylaxis. So we say egg anaphylaxis when there is more than just cutaneous reaction, there's a respiratory symptom or cardiovascular symptom. In these cases, I would suggest refer to the allergy service. Influenza vaccine is the other egg-containing vaccine. Higher quantities, maybe nanograms of egg protein. However, it can still be given in the primary care setting without any further observation. Again, special precautions in the egg anaphylaxis cohort. Finally, egg yellow fever vaccine. These are cultured in chick embryos and measurable amounts of ovalbumin, and hence when we have such a case, we either give it as a graded vaccine or desensitization. This is a table of some of the common MMR and flu vaccine that we have. So you note that the GSK ones doesn't have gelatin, but the Merck ones have gelatin, so just keep that in mind. For the flu vaccines, they are largely comparable with trace amount of egg components. So going to some of the other specific adverse events. So this is the updated NCIS effective from the 1st of November. I have to emphasize very to the general audience, we need to know our schedules, how to be sometimes flexible about it, the route of administration, as well as the intervals, you need to know it very well. Most of the vaccines are oral, for example, there are only 2 oral vaccines, which is the rotavirus vaccine. OPV is largely sort of phased out. Most of the vaccines are intramuscular, but we do have the option to give it subcutaneous if there's a bleeding tendency, for example, in a hemophilia patient. Subcutaneous vaccines are less painful. Usually the MMR vaccine, as well as the flu vaccine, yellow fever vaccine, you can give it that way. BCG is intradermal. So for BCG vaccines, you won't be giving it. It's given at birth. But these are some of the possible complications like deep ulcers as well as injection site abscesses. They are not common. If you see them, if it's significant, it may be worth referring. Suppurative lymphadenitis are, again, most times it's just a small lymph node about a month after the vaccine. Reassure parents, don't need to sort of dress it. It will disperse sort of like naturally. But if it's a large, if it breaks through with pus, then we'll usually refer to the surgeon for sort of like drainage. Because of the vaccine monitoring adverse events, this is a slide that we share with HSA. We investigated a spike of BCG lymphadenitis, and we can sort of localize it to a vaccine batch problem. And this problem seems to have occurred in various institutions, so we know it's not a the way it's administered. Next slide. I think the clicker is not working. Next slide. Yep. Next. So BCG, because it's a live attenuated vaccine in some special circumstances, these are rare diseases we call primary immune deficiency. So in my KK visiting clinic, I still attend to these primary immune deficiencies. They can cause nasty disseminated BCG infection, mostly in our severe combined immune deficiency in the pictures on the right. It can cause osteomyelitis. It can cause disseminated into the skin as well into the gut. For Hep B vaccine, I guess you still need to take note of the 5% hepatitis B carrier mothers. For the new schedule, there's no changes for dose 1 and dose 2. We still recommend monovalent Hep B vaccine. But for dose 3, it can be combined as a 6-in-1 vaccine to facilitate administration. I do recommend checking the anti-HBs antibodies at 9 months because there's a small group of vaccine failures and you need to repeat them. These are yeast-containing vaccine in case of hypersensitivity reactions. Next slide, please. Oops. Rotavirus vaccine, just to emphasize, is meant to be orally administered. I would usually find that some babies it's best to give it before feeding, so tell the parents before they come not to feed milk to the baby. Give it slowly, as sometimes it can induce a vomit because it's cold, especially in those babies who are prone to gastroesophageal reflux. The schedule, there are 2 main rotavirus vaccine, the Rotarix as well as the Rotatag. 2 doses for the first one, 2 months, 4 months, and there's some time guidance for when is the earliest and latest. Rotatag vaccine 246, and again some guidelines for when is the last shot. It can cause a mild gastroenteritis because it's a live attenuated virus, but it also can lead to the presentation of severe combined immune deficiency because they cause a severe diarrhea. So this is a slide shared with me from HSA, so it's not for circulation. We do collect data on interception, and we do have about 1 to 5 cases every year for the last 10 years. Median age about 4 months, time to onset about 11 days, ranging from 1 to up to a month down the road. Mostly successfully reduced by air anemia, but a few cases required laparotomy. So this is a side effect of the rotavirus vaccine. But it's pretty rare. DTP vaccines, It can cause a large local reaction, mainly due to the tetanus component, and hence for the second booster that we give in P5 is a reduced diphtheria pertussis dose. There's an association with GBS, but rarely reported. Pertussis is one of the vaccines we are quite careful in sort of pediatrics because in the past it's been associated with quite a lot of encephalopathy. But since switching to the acellular pertussis vaccine, this has largely reduced. Some babies have this rare epilepsy syndrome called Dravet syndrome, and the vaccine can unmask these seizures and lead to sort of like epilepsy. But in the large majority of patients, it's just fever, local reaction, and maybe a seizure. Pneumococcal vaccine, again, is linked with fever, febrile seizure, large local reaction. In our invasive, in our investigation for invasive pneumococcal diseases, sometimes we can detect vaccine drifts to the non-vaccine strains. So sometimes it's due to vaccine failure. Pneumovax vaccine, again, special indications for those with compromised immune function. I find that useful to help me assess vaccine immunogenicity as well as their immunity function. But they are notorious for causing a bit of adverse reaction. Next slide. Influenza vaccine, there's a risk of anaphylaxis as well as GBS syndrome. For interest of time, I won't go through the details. Next slide, please. Again, we have some local data, about 5 cases reported in the last 10 years. I think it's much less than the background incidence, and currently I don't think there has been good evidence to link the two. Next slide. Okay, for MMR vaccines, I think it's important to caution your families. This is, again, a live attenuated vaccine, so do expect some delayed fever, usually ranging from 5 days to up to 12 days. Some may develop a rash and be surprised by it. Again, tell them about it. We suggest to separate MMR and V for the first dose because of association with febrile seizure. There may be some thrombocytopenia as well as arthralgia. None of them are contraindications for the MMR vaccine. Anaphylaxis, like I say, is fairly rare. Next slide. Finally, one slide on vaccine adverse effect. Next slide. If you do encounter any of these vaccine adverse events, including severe adverse events, particularly when the new COVID vaccine may be coming to Singapore soon, you can notify it. This is a website in HSA, and you can use that sort of like prompt to go into the website itself. Okay, next slide. So I'd like to summarize. These are some of the adverse events that we have just gone through. Vaccine reactogenicity, may it be local or systemic reactions, hypersensitivity reactions like urticaria and anaphylaxis. And for some of the specific vaccines like BCG with local disseminated ones, hepatitis B for vaccine failures, rotavirus for interception, DTP for encephalopathy, influenza, for example, for allergic reactions, or MMR with those reactive arthritis. You may want to notify, you may want to refer on to your friendly pediatricians who are able to advise your patients. Okay, I thank you very much for your attention.
Thank you very much, Dr. Liu. That was a tremendous sharing. Next up, we're going to prepare our speakers for the panel discussion. And what you could do as live viewers, get your questions ready. On the bottom right of the screen, there is a Q&A call-out button where you could pen down your questions. Once your question is approved, it will appear in the approved questions list. Our panelists will take time to answer them. And also, we'd like to just highlight to you, for those of you who wants to make an appointment with Mount Elizabeth Hospitals, you could use this hotline, yes, and also the WhatsApp number to contact us. And finally, we also want to give a big shout out to our sponsors. This event would not be possible without our sponsors. Platinum sponsor, Teleflex and Pfizer. Gold sponsor, Sandoz, and silver sponsors, Beringer Ingelheim and GSK. Thank you so much. And of course, we'll now like to come to the Q&A panel discussion for today's webinar. Let us now welcome Dr. Ashok, and also let us welcome Dr. Liu. And our moderator will be none other than Dr. Leong Ho Nam, infectious disease physician. Over to you, Dr. Leong, if you're ready.
Hi, we're going to all take off the mask here for this discussion. So very quickly, I enjoyed the talk very much, and I'm going to start off the first question with Ashok, my good friend. COVID-19 was very much a respiratory disease as we understand it to be. But from your description, it looks more like a multi-systemic, it looks like a systemic syndromic disease rather than just a respiratory disease. What do you think?
Yeah, so unfortunately, we are on the learning curve in that regards. But it is true, it is not just a respiratory disease. And we have to understand that we have to keep up with the science, because I think I may have mentioned that there is an infodemic, and there's also a lot of media hype. So when people talk about syndromes like long COVID, etc., you have to tease out the science from the fallacies. And this is a big problem that's going on in the US right now. To better understand the problem, they have to think of strategies to come up with better way to understand the science. But as we know it, even in the acute phase of presentation, it is not just involving the respiratory tract. It also involves other systems as well, from the central nervous system to the cardiovascular system to the blood and so on and so forth. So it can also happen in the recovery phase, and it can happen in the form of like an autoimmune or an immune-based phenomenon, just like what we described in the multi-system inflammatory disease, both in children and now beginning to be understood in adults as well. So there are a lot of things that we don't really understand about it, but if you ask me, the short answer to it is yes, it is not just a respiratory virus.
So in a way, the nightmare that doesn't seem to end for all of us sometimes doesn't end for the individual that's stricken with the illness as well.
That is true. So therefore, but not everybody ends up with this long COVID or this so who actually ends up getting it? And in the US, they are actually trying to tease out whether or not it is because as you know, in the US, the people who end up getting COVID happen to be the racial minorities and all kinds of. So are they the ones who are also coming down with long COVID? This is where the science is not clear. And we need all that information as well. In the local context in Singapore, I don't think we are seeing as much as that, but we had a completely different spectrum, right? I mean, our epidemiology is vastly different. So I don't think we can really truly appreciate that problem locally as of now, but we have to still understand the big picture overseas and take it from there.
Okay, I'm going to ask Ashok the second question, which will also lead to your comments after that, Wei Kang, which is mRNA vaccines. And mRNA vaccine is totally new. We've never seen it.
Yeah.
But of course, you try animals. Can you take us through how the mRNA vaccines work? And can it actually incorporate into the human DNA? I mean, that's what we are all worried about.
So to answer the second question first, there is no way that it can incorporate into the DNA, because it's a new platform of the new technological platform, because this was not something that we had done before, but because science had evolved before COVID-19, these platforms were already being studied in a way. And then, of course, with the COVID-19 evolving, they juxtaposed upon all this science that was evolving, and hence they could quickly come up and engineer these mRNA vaccines. So unlike other more traditional based vaccines, when we talk about mRNA vaccines, they are using the genetic blueprint to actually tell the body to go manufacture that part of the virus that is actually going to be antigenic and that can actually give an immune-based response. So in the context of what we understand from SARS-CoV-2, it is the spike protein that is one of the things that the virus has been known putatively to be associated with virulence. And hence, if you actually just give an injection containing the genetic blueprint, but actually it's coated in a lipid nanoparticle, it is because you want to evade the innate immune system. Otherwise, everything in the body will start to annihilate. These mRNA vaccines are very fragile. So the nanoparticles comes in with this lipid layer, they get protected, but once they enter into the cells, then the lipid is actually dissolved out, and then you basically get the mRNA. But all the action happens in the cytoplasm. It does not involve the nucleus. Hence, there is no way. The message is read, and the proteins are manufactured within the cytoplasm. So there is no issue of that going into the DNA. So hence, there are a lot of fallacies that you read about, and people should just stick with the facts.
I agree. I agree. Wei Kang, you have anything to add to that?
Yeah, I think it's certainly very unprecedented times. We have all this technology preparation in the past, but this is the time they introduced it. In childhood illnesses, we have, with over time, been even using gene therapy and various other therapy to cure diseases. But the big difference is we are targeting the genes to be inserted into the DNA. So the vaccines, I'm reassured by it.
Okay, so we have mRNA, but to incorporate it, we actually need, I remember something about RT-PCRs, you need reverse transcriptase. So without the RT-PCR that's found in, humans just don't carry it, but some of the retroviruses do carry it. So without it, we can't incorporate it inside. And so far, the data coming out has been quite good. I think we have more than easily tens of thousands of individuals who collectively have done the vaccines in China, as well as in the UK and US. But Wei Kang, do you think the vaccine is quite safe at this point in time?
Yeah, I think from the data that has come out so far, we are all reassured by the safety data that has been published. I guess we are already starting entertaining inquiries from your friends as well as patients about this. So I think we will have to continue to look at the science that's coming out. But at this moment, I have no concerns about the vaccine.
Okay, recently AstraZeneca's vaccine, which is not approved yet, I don't think it's been approved in UK. UK actually approved the Pfizer one, caution a case of transverse myelitis. Is that of any concern to you?
Yeah, with regards to all the sort of severe possible vaccine adverse effects, I think we have to always remember what is the background disease burden in the background. Meaning, for example, Guillain-Barré syndrome association with influenza vaccine, and I guess recently in South Korea where they reported a lot of influenza-associated deaths. If you overlap all these data with their background mortality in that age group, you'll realize that it's sometimes just an association rather than a true adverse event.
Just to add a point that I think, yeah, the transverse myelitis, one, if I'm not mistaken, was associated with multiple sclerosis in that particular patient. And another one was, I think, 68 days or something like this after the vaccine. They couldn't actually determine that it was the vaccine that was implicated. Yeah.
So unfortunately, even as a person receives the vaccine, life goes on. I could still develop cancer as I'm getting the shot because my body's still at risk of cancer, or I could be developing diabetes because I ate too much of a good food early on for lunch. But these conditions will still happen, but not that it is associated with the vaccine, but it's just very coincidental.
Yes, I'll agree with that. I guess other than that, I will be looking closely at what is the long-term protection and the immunogenicity of these vaccines.
Excellent. I totally agree.
Just another point, the vaccines, they don't prevent COVID because we don't know that it can actually prevent asymptomatic COVID. That is not been established. What we know is that the vaccines, the Pfizer BioNTech was basically in the context of symptomatic COVID and also for severe COVID prevention. The data that is about asymptomatic COVID is unknown. So we don't know that part of it. So when people go about with their business in the context of safe public health, living, etc., you have to still follow the rules. Even if you had the vaccine, it's not therefore that so-called immunity passport, and hence, you don't need to do all the social distancing and the masking, and you think that you're not going to get the disease. That's not true.
I'm going to carry it the other way forward, Ashok, with your question, or your statement rather. So you get vaccinated. I don't develop symptoms. I may be asymptomatic, but that in turn, I may still pass on the virus to other people.
Yeah, because we don't know that because we don't have the science. So therefore, the protection that is, the fact is you're not going to fall sick from the COVID, but it does not mean that therefore you can't get the asymptomatic version of it and hence pass it on.
Agree. So in other words, we still have to watch this space.
Yes.
We really don't know how will the vaccine play out. Even if we have the vaccines, we must still wear our surgical masks. We must still maintain our distancing so we don't spread on to other people. Australia has certainly asked for people who are entering the country to get vaccinated before we go ahead. But nonetheless, I think it's a forward step, and vaccines actually have eradicated many viruses. So I'm going to ask the two esteemed experts here. Do you think the COVID-19 is going to be a game changer, no doubt. But do you think COVID-19 vaccine can eradicate the virus like it did for smallpox?
I think if we look at the previous coronavirus history, we have 4 that's currently already actively circulating. I don't think so. I think it will become milder with time, and hopefully we can prevent the severe COVIDs that we are seeing now. The virus would mutate and we have to catch up with it.
I think that you are also in a very good position to answer this question yourself. But I think that we will, for sure, I totally agree, we cannot see the end of this is also the WHO's stance. And the fact is also that there is a lot of anti-vaxxers. Right? Because it's just not only for all the childhood vaccination programs that are in other parts of the world where people just don't want to go for all these vaccines, and you don't know what it takes to get onto herd immunity. As of now in this country, it seems to be not so bad, but who knows, right? Because we are so porous and we have a lot of importation cases, and they continue to give us trouble and expose potentially weak links. So I not only for people who are not going to get themselves vaccinated, and then there's so many people involved, I just don't think it's going to be possible. It may end up like influenza.
So we have a lot of unknowns. Number 1, how long does the vaccine last? Number 2, people who do not want to get vaccinated. Number 3, we also know about people who can get reinfected again. So in other words, I would side with, I would agree with what Wei Kang has said and what you have said too as well, Ashok, that I think the virus is here to stay. It's going to be a nightmare that's not going to end. Instead of 4 circulating coronavirus, they're going to be the 5th one. Okay, before we end off, I want to ask Wei Kang this dying question, because I know that the audience out here are not just Singaporeans, but in fact, there are doctors from all over the region. MMR vaccine, for example, in the region is given differently from that of Singapore. So why is it so? What should we do if I'm in Indonesian, if I'm in Thailand or Philippines? What should I do? Should I follow that one, or should I do the one in Singapore? What is better?
Yeah, I think that's a very good question. Thanks for raising it. Measles, we usually follow the vaccination schedule of the local country you are residing in, because it depends on the incidence rate of measles in your country. But for long-term immunity, we do know that if you give it before 1 year old, the data for long-term immunity is not so great. So for Singapore, we have chosen to give it the first dose at 12 months, with some flexibility up to 4 to 5 days before 1 year old birthday, and then the second dose from 15 to 18 months.
Agreed. So if you give before 12 months, there's a risk that the maternal antibodies will neutralize it and make it less effective. But I agree with Wei Kang. At the end of the day, is follow what your country guidelines say. That would be the best, because you have to take into consideration the epidemiology of the disease there. So I think we're coming to the end of the question and answer session. I really appreciate you guys staying all the way to the end. If you enjoyed this, see the link, subscribe, and give us a hands up to this. Take thumbs up to this. And if you like more of this, share with us. Share with us what other topics you want to talk about, what topics you want to listen. You see, we will want to hear from you so that in turn we can actually share the good news on good health. All of us can have good health together. Thank you.
Thank you very much.
Thank you
Merry
very much.
Christmas, everyone.
Yes.
Thank you to all our doctors, our moderator and panelists. Thank you so much for the sharing. And yes, do remember to like and share this content so that a lot of people, a lot of viewers can get to learn more about our topics that we shared today. And of course, this is not all. This is our very inaugural session. We have 3 more sessions upcoming. And also, we'd like to highlight to all of you, if you want to make an appointment with Mount Elizabeth Hospitals, you could WhatsApp us or simply call us using this hotline number over here. And finally, of course, our next session will be the 12th of December at 1 p.m. We have Dr. Lim Chun Ping, cardiologist, as well as Dr. Tan Ike Hao, respiratory physician. And we also have our moderator, Dr. Goh Pin Pin, who's a cardiologist, who's going to moderate this panel discussion. Last but not least, we'd like to thank all our sponsors once again for the tremendous support for making this event possible. My name is Charlene, and thank you so much to all our viewers who's watching us right now. And we shall see you our next session. Goodbye.